My name is Alex, and I will discuss a situational analysis on the topic of postoperative pain assessment and management. Are there problems? Yes. Even though the most common postoperative patient fear is pain and advances in postoperative and acute pain management, postoperative pain continues to be poorly managed. Inadequate pain management can lead to a cascade of metabolic responses which can impact activities of daily living, quality of life, mood, nutrition, organ function, and sleep, as well as increased risk of developing chronic pain syndromes, postoperative complications, morbidity, and mortality. In post-op, this can impair recovery, metabolism, exercises, and nutrition. The economic impact of uncontrolled pain or prolonged pain includes burden of disease, hospital and patient costs, loss of productivity on both the patient and societal level. The following are some statistics. More than 40% of patients suffer from moderate to severe pain early after surgery. Under half of post-operative patients report inadequate pain relief. Children are often inadequately treated for pain due to an incorrect belief that they feel pain differently. Men are less likely to report pain and would report more control over pain. Even with the same conditions, women usually report higher levels of pain. Pain in older people is often not well managed for a variety of reasons. These include coexistent disease and concurrent medications, age-related changes in physiology, pharmacokinetics and pharmacodynamics, altered response to pain, and difficulties assessing pain. Additionally, older patients may be hesitant to request pain medication, believing that pain is an inevitable consequence of surgery that requires tolerance. Through my research, barriers were able to be described as stemming from a lack of knowledge, fears and myths about medication, pain, and pain management, which contributed to a mismanagement of pain by healthcare professionals, patients, and families. They are as followed. Patient-related barriers include fear of opioid addiction and side effects, communication gaps between patients and providers, impairment including disability and language, the subjective nature of pain, and psychosocial issues. Nurse barriers include lack of medication knowledge, attitude on opioids, attitude on postoperative pain, poor pain assessment skill, underassessment and misjudging pain intensity, lack of cultural sensitivity, poor documentation, poor communication skills, staff availability, lack of organizational support, pain is failed to be seen as a priority, judge pain rather than asking or assessing, assuming pain is at the surgical site, under recognition or under treating the other influences of pain, that is the quality of life domain. System barriers include access to provider care, reimbursement, cost of prescription, lack of resources, lack of staff, fear of regulatory scrutiny, broad guidelines that aren't procedure specific. The following recommendations are for pain assessment. Accurate, objective, and routine pain assessments must be done. Let the patient know that you intend to assess their pain to foster trust. Encourage patients to tell you whenever they experience pain rather than waiting to be asked. The presence or absence of pain should be assessed whenever other vital signs are assessed. The patient reports pain in every 2 hours after that and after interventions. Referred pain must be considered when interpreting the patient's pain. Misdirection can lead to inappropriate diagnostic testing and therapies. Patients' pain are usually assessed when resting. However, a better indicator of pain management would be the assessment of pain upon movement. Before beginning any assessment, recognize that patients may use words other than pain. For example, older adults may deny that they have pain, but respond positively when asked if they have soreness or aching. Document the specific words that the patient uses to describe pain. A simple mnemonic that acts as a framework for the pain assessment is PQRSTU, which stands for provoking and palliative factors, quality, region and radiation, severity, time factors, and pattern. Understanding of pain and pain management. Numerical and verbal descriptor scales are used to determine pain intensity, and they work well for most adults. However, visual pain scales, such as the FACES pain scale, may be more useful in patients with cognitive and/or language barriers. In instances where a patient cannot articulate their pain, the nurse may need to use non-verbal information to conduct a pain assessment. Typical symptoms are listed. Please take a moment to read them. The following are recommendations for pain management. Pre-operative education, patient assessment, and understanding of a procedure is proven to positively impact pain management post-operatively. Reassure the patient, provide education, answer common questions, and provide opportunities for the patient to ask their own questions in order to psychologically prepare them for surgery. Always treat the underlying cause. Pain relief should be given based on their pain score unless contraindicated. Analgesia administration should be focused on preventing and controlling pain rather than administering it once it's bad. This includes scheduling when there is no activities that are expected to produce pain. Fast-acting analgesia should be used for breakthrough pain, whereas long-acting analgesia should be given for persistent pain. Pain relief is most effective using a multimodal and biopsychosocial approach. Pain control involves ongoing pain assessment, administration of prescribed medications, both opioid and non-opioid agents, and non-pharmacological methods of pain relief. Example, relaxation breathing. Furthermore, the choice of analgesia should be based on the evidence for that particular surgical procedure. So I'm just going to be talking about some hypothetical ideas or thoughts that popped into my head while researching this topic. It was mainly based from deductive reasoning and some creative thinking. The continuation of research for better approaches, both acute and prophylactically, safer safer and more effective drugs, safer and more effective polypharmacy and therapies, better surgical techniques, and technological advances. Increase the prevalence of acute pain services. They communicate with staff and patients and oversee education of pain management, including pain assessment, analgesics, and non-pharmacological interventions. Facilitate a culture that encourages staff to practice safe and to be better. Empower staff to learn to be better, become more educated in order to be more efficient and safe. This can tackle the issue of ineffective in-services because staff will want to do their own research. Encourage staff to recognize practice that is inappropriate or dangerous and to speak up. Challenge outdated practices and policies. Educate and help one another. Staff should be encouraged to make a presentation about things they have learned on their own self-researching journey and that they have found interesting and or feel like it is of importance, just like this one, and present it to their colleagues to facilitate focus and engagement. Current education is outdated and ineffective. Education is to continuously adapt and should be taught in a variety of ways that have been proven to work in achieving learning goals, including a variety of engaging teaching styles and formats, and even going as far as being individualized. Think of student-centered teaching. This is much more than the traditional lecture medium for all students who have their own learning strengths and weaknesses. Teach relevant, up-to-date, evidence-based knowledge. It's all too common for the same knowledge to be shared year after year with little to no change. If emerging healthcare professionals are learning the same content that healthcare professionals were learning 10 years ago, not much is going to change. Research is always providing insight and suggesting change. Education should match the speed of research. Teach about contemporary issues, but most importantly, how to prevent them. Have a considerable amount of time teaching and self-learning directed at the topic. Example, a total of 50 hours given to the topic of pain throughout the course. Education should continue throughout the healthcare professional's career. Partly involve practical classes which are more physically engaging. A transition into practice where students are supervised and guided, as well as prompted to critically think, provide rationale, and to reflect on practice, all the while being held to the standard of best practice. Challenges to my proposed ideas include adequate staff to patient ratios, staff to student ratios, resource availability, especially remote and rural, funding and level of interest. Further research will probably be slow and scarce. Previous studies suggest recommendations for areas that need investigating and further researching, but if and how long it will take happens to remain unknown. Simply, pain and its assessment and management does not have the undivided attention of researchers and investors. Based on my research, the implications for future practice is mainly three things. 1. New assessments and interventions will become recommended and they will be procedure specific. 2. There is going to be a high demand for staff and specialists. 3. A need and progression of high level of clinical knowledge for current and emerging healthcare professionals. To conclude, the prevalence of inadequate postoperative pain assessment and management have remained consistent over decades, with findings like barriers and common issues being strikingly similar across many studies and research articles, despite the publication date ranges. The results have also remained similar from countries all over the world, which also suggest an international unresolved problem, despite updated guidelines, evidence-based action, and novel treatments. Here are the references. Feel free to pause and look them yourself. Thank you for watching.